thank you all. And again, thanks for the opportunity to speak with you today. And good morning, afternoon, or evening, or wherever you might be joining from. Before I begin, I'd like to note that I have no financial relationships to disclose, and the opinions expressed herein are mine and not representative of the NCI, the NIH, or the U.S. federal government. Today, I'd like to speak a bit about where we are in the field of dissemination and implementation research, or science. And again, the nomenclature here in the States is more of the D&I or IS, so I'll use that, but certainly that is similar to KT. So talk about some reflections on the state of the science and a few methodological and content areas that I think that are particularly ripe for growth and opportunity, both with respect to advancing the science and the potential to have a tremendous impact on improving population health. And I'll close with some resources and funding opportunities that are available here from the NIH to help move the field forward. Some reflections on the field are as follows, and based on conversations I've had and been lucky enough to interact with thought leaders in the field, as well as the literature review and attendance at conferences, and just trying to get kind of a snapshot or a landscape analysis informally of where we are. I think we have a solid knowledge base of implementation strategies, or ways in which we're able to implement evidence-based interventions. We're starting to unpack implementation mechanisms and better understand ways to track what, how, and why strategies are being used during and throughout the implementation process. We have a plethora of implementation theories, models, and frameworks, and I think, Sharon, in fact, you are a co-author on a review that found over 150 of them a couple years ago. So we certainly have a lot, and we're getting better, I think, importantly now at understanding which one to use, how to use it, and why to use it, and to leverage that theory, model, or framework to inform all aspects of the implementation process, whether it's implementation research or implementation practice. And we have resources for selecting theories, models, and frameworks, including some interactive websites and some websites that are specifically focused on a couple of the more prominent theories, such as the CFIR, EPIS, and REAIM. We see implementation research being represented and conducted across diverse contexts, delivery settings, populations, and content areas. And we have training programs, textbooks, courses, webinars, workshops, and other resources aimed at building research and practice capacity in implementation science. I think arguably we're moving toward implementation science 2.0 or maybe even 3.0, again, depending on who you ask, which is an incredible advance in quite a short period of time. Today, I'd like to highlight areas where I think there's an opportunity for growth from both a scientific perspective and from an impact perspective on improving patient and population health. These areas include de-implementation of ineffective health practices, implementation study designs, including rapid cycle intervention research and pragmatic implementation trials, data sharing and implementation science, and climate change and implementation science. De-implementation is increasingly recognized as a significant problem. It contributes to wasteful spending, inefficient use of time and resources, causes unnecessary harm to patients, and can damage public trust in the healthcare and medical research enterprise. We're increasingly identifying practices for which we thought we knew they worked, so to speak, but in fact, newer evidence indicates that they don't, such as medical reversals, or that they cause more harm than good. And in fact, they've documented hundreds of examples of medical reversals across different health areas and patient populations, and quantified the harm that is done from overscreening, overdiagnosis, and overtreatment for many health conditions, including those that are most common, such as heart disease and cancer. There are a lot of similarities between the implementation of an evidence-based practice and the de-implementation of an ineffective practice, both with respect to how they occur in the real world as well as how they can be studied. I wouldn't say necessarily that they're two separate areas of inquiry or two separate distinct fields. There are, again, a lot of overlap here with respect to conceptualizing it as multi-level factors that can facilitate or impede implementation or de-implementation. There are theories, models, and frameworks for each of those. A recent scoping review found over 20 for de-implementation specifically. And there is also guidance around how to study the process. And of course, a recognition that context is paramount for both implementation and de-implementation. And there are many multi-level determinants where multi-level determinants that would be the target of strategies to overcome those barriers. But I think there's also some distinct differences between the two, where I think there's an opportunity to advance our scientific understanding of de-implementation. So the starting point, of course, is different. The starting point being something is currently being used or overused within a healthcare or public health delivery setting, which means that the type of action is going to need to be different than trying to implement something or increase the use of something currently. And so some determinants may be the same for implementation and de-implementation as mentioned, but there are others that I think are either more pronounced or unique to de-implementation, and particularly the role that affect and emotions play here, both at the patient and the provider level, specifically, such as fear of missing a diagnosis, if you don't do screening every year, fear of medical malpractice, if you don't order a test or you don't do a procedure. Habits and the literature from social psychology on habits and how to try to break habits to the extent that this is maybe something that patients have been experiencing or receiving and providers have been receiving, delivering over time, and how to adjust or break that reaction to what should be done if one is in fact supposed to not do that or reduce the frequency with which it's being done. We, at least in the States here, live within a system where reimbursement certainly drives a large part of what is provided and done, and certainly supports doing more rather than doing less. And the fear of medical malpractice, which encourages doctors and providers to err on the side of more rather than less, and kind of the prevailing cultural sense that more care is better care. So de-implementation also brings into focus a level of evidence for an intervention. So at what point does a practice become harmful? Is low value care low value for everyone or just low value for some? And if we don't know if a practice works, should it be de-implemented just in case? Or should we focus more specifically on something that we know doesn't work and have strong evidence that it causes harm and should de-implement that first rather than focusing on something for which we don't know if it works? And also questions into what is the amount and type of evidence that determine whether something should be de-implemented. So in implementation science, there are a lot of conversations around how much evidence is sufficient to warrant implementation, and fewer conversations around what that means for de-implementation. And of course, de-implementation strategies that are needed to address de-implementation specific determinants. Again, some of the unique aspects for de-implementation, such as addressing fear, anxiety, uncertainty, unlearning, replacing one practice with another, or changes to reimbursement, all factors that one could identify and test in trials to identify effective de-implementation strategies. I wanted to offer up a few questions to illustrate opportunities for growth in the field. And the first here is the idea that de-implementation can actually be a starting point for implementation rather than a separate process entirely. And so we know that one of the major barriers to implementation, or some of them, are cost, time, competing demands, and resources. And so to the extent that if we can de-implement a practice that we know doesn't work, can we create that use that as an opportunity to create time and space to support the implementation of practices that we know are indeed effective? And so maybe starting with de-implementation creates momentum, motivation, and a sense of collaboration and cohesion among groups involved in doing so, that it provides a springboard for effective implementation as a next step. And here we see some examples touching upon this idea, with one from the education literature and others emphasizing the importance of time and team-based generation of things to de-implement, including one of the favorite titles of an article that I've ever seen, Getting Rid of Stupid Stuff. Another opportunity for growth is understanding how best to communicate the need for de-implementation without losing trust among patients with whom de-implementation would occur, as well as the broader implications for public trust in healthcare and medical research, broadly speaking. So what are some of the ways in which we can communicate with patients that de-implementation needs to occur, but to minimize any decrease in trust as an essential component toward effective de-implementation? Again, something that might be particularly relevant or unique to de-implementation. How do we communicate about this such that we don't decrease patient trust in their providers, as well as patient and public trust in the health research enterprise, broadly speaking? And so ways in which not just a type of patient-provider communication around specifically a particular screening test or drug or treatment, but also ways in which we can communicate why something is no longer needed, especially without increasing miscommunication or misunderstanding or leading to negative consequences down the road. And one last example here is where we can identify more research and the potential for advancing de-implementation and better understanding how de-implementation might actually have direct or indirect negative unintended consequences, including, again, the potential for it to lead to or increase mistrust in the system, as I just mentioned in the previous question. So how can we ensure that our successful efforts to optimize care that includes de-implementation are not met with resistance to use of effective programs among care teams down the road, for example, or disengagement of patients in clinical services entirely? To the extent that we will always need to de-implement a practice, ideally because something better comes along that addresses the same issue and same health concern, rather than a medical reversal that shows that something that we're doing currently actually doesn't work and causes harm. But regardless, I think thoughtful consideration, long-term assessment and studies, and planning and anticipation for how to minimize the potential negative reactions that we have from patients, providers, and systems and the public, broadly speaking, will help us in the long run. So I'd like to switch gears a little bit here to the second topic, which I think is primed for further understanding and advancement. And these are two methodological issues in implementation science that I think would benefit from advancement and deeper thinking and would be importantly applicable across the board and not unique or specific to one particular health disease or population. And so the first methods issue is this notion of rapid cycle interventional research, which we define as a rigorous approach to conducting interventional research that seeks ways to maximize the timeliness and efficiency of the process for generating answers to questions of practical interest and actionable use. And the second is the conceptualization of implementation trials along the pragmatic explanatory continuum. So with respect to the first, why do we need rapid cycle interventional research? Given the rapid pace of change in healthcare service delivery, various stakeholders are making it clear and continue to make it clear, of course, that we can't afford to take 5 to 10 years to move from concept development to testing to adoption to looking at improving certain aspects of clinical care. And there's also this growing recognition that we need to improve the efficiency and accelerate the process of developing and testing not just new interventions, but apply this to implementation strategies as well. So we find ourselves in a situation now where many of the more rigorous and reproducible approaches don't meet the needs of stakeholders, given the time and resources required to generate findings. But many of the quicker approaches to improving care are lacking in rigor and reproducibility, which limits their usefulness of findings largely to specific settings in which they were first generated. So rapid cycle research, interventional research, isn't a brand new concept in implementation science. And more than a decade ago, there was a seminal paper calling for more research that is rigorous, rapid, and relevant, and further emphasized within the idea of the learning healthcare system. But as an extension of this conceptualization, we, colleagues and I, further kind of define and operationalize rapid cycle research specifically to interventional studies, which includes but isn't limited to implementation strategies. And so we propose that there are 6 elements of rapid cycle interventional or strategy research shown here. And not all of the elements are necessary per se to be considered rapid cycle interventional research. But certainly they are elements that when present should lead to the creation and the generation of evidence that is more actionable and more relevant and responds better to the needs of stakeholders and collaborators and partners in generating an answer that is robust to a question that they are asking and a question that they need an answer to. So the first element here, and arguably one of the most important, is the use of iterative study design features. And this includes designs such as sequential multiple assignment randomized trial, or SMART designs, as well as multi-phase optimization strategy, or MOST, such as factorial designs. And we're seeing a lot more of this in implementation science, where they're randomizing different strategies to different conditions rather than randomizing at the intervention level different components of an intervention to patients. So I think there's a real opportunity here to tailor this and build on what is emerging as some really cutting edge different designs that have rigor and that are iterative and fit nicely and lend themselves well to supporting this broader rapid cycle interventional research. The second element is a focus on proximal primary outcomes, which means a focus on outcomes that would be expected to be influenced in the shorter term by the intervention. And so one of the reasons, of course, is to facilitate earlier ability to answer questions or get an earlier read on the likelihood of the intervention having the desired effect. And these are often implementation outcomes used as proxies for the delivery of clinical practice guidelines, which then, of course, is hypothesized to improve patient health outcomes. Which implementation outcomes are best suited as a proximal primary outcome and measured at what point in the process remains an open question, and where there could be some additional thinking in this area, not just focused on interventions, but again, focused on strategies. The next element is partnerships. And we all know that engagement, broadly speaking, has the potential to yield research that is more patient-centered, practitioner-centered, feasible, acceptable, and relevant, and can lead to greater uptake of results by patients in the healthcare community. And certainly that is integrated into implementation science throughout the entire process. And from a rapid cycle perspective, we can see how stakeholder engagement can have a positive impact on identifying the priority topics and the questions, as well as the selection of the study design, the outcomes, and the implementation strategies. So leveraging and collaborating with these partners throughout the process, not just at one point along that continuum of the study. This includes engagement in identifying what the subsequent iterations, for example, of a SMART trial design would be, as well as identifying what outcomes, proximal outcomes, would be important to stakeholders and other elements of the rapid cycle interventional research study. The next element for consideration is data sources. So here we want to focus initially on existing data or secondary data as the source data for which one may be able to use as the primary proximal outcome. So it's not to say that primary data collection makes it this not rapid cycle interventional research per se, but more so that can we capitalize and leverage the opportunity for data that's already being collected to use that efficiently as a way to answer the questions. And so this is often within EHR, electronic health records, and associated data warehouses or administrative records. And these are some of the examples for which it might be possible, and we see this being used increasingly so in healthcare research with patients and patient reported outcomes that are collected in EHR systems. So essentially trying to facilitate the rapid aspect here by making making best use of the data that are available. The fifth element here is context, where the study will be conducted. So we're talking about the infrastructure that's needed to support this type of research to truly make it rapid. So this includes clinical leadership, staff support, ability for investigators to organization to collect data or assess data that are already being collected and access it, and the ability to do the analysis. excuse me, and the last element here is rigor, tying into the iterative study design. And I think, of course, the best study design is the one that is best equipped to answer the research question or questions, but that's also feasible and acceptable to be conducted in the study. So there's some general agreement that some designs are more rigorous than others, and certainly in trials, we're often leaning more toward the randomized trial design or quasi-experimental, such as interrupted time series, so we can maximize internal validity while also maintaining external validity by involving our partners and stakeholders in conducting these studies within routine, quote unquote, real world care delivery settings. These are just a few examples of how rapid cycle interventional research is being conducted in implementation science, currently including the great work that you all and your Canadian colleagues have been leading for some time on testing iterations of audit and feedback to improve and increase guideline concordant care through the audit and feedback meta lab, which I think is fantastic and a great aspiration for all of us to look to as an example. And I think that's something that we try to consider and conceptualize, this idea of implementation labs, in which one of our signature NCI-funded initiatives, the Implementation Science Centers and Cancer Control, was instrumental, where ISC3 was instrumental in generating these and creating these, I think, in large part on the idea of implementation labs, where you can conduct these types of nuanced but very important studies where you can manipulate and change things like you do in the audit and feedback meta lab, of how does this affect, this change affect this outcome? That outcome wasn't changed. Let me try another incremental approach and try this strategy. So really, I think showcasing the work that you guys have done as leaders in the field on implementation labs, and again, truly in the sense of a lab in which this work can be conducted. And then just to note, a really nice article by Horowitz and her colleagues that they did 12 randomized trials within the learning healthcare system, and really great examples there too. And for those that are interested, speaking to kind of the adaptive or iterative rigorous designs, there's a recent article showcasing some of these and how they're specifically applied to implementation science. So building on again within kind of the structure of research studies, talking about pragmatic and explanatory trials. And so folks, I'm sure, well, many of you, I'm sure, since some of the leaders have been Canadian colleagues in expanding and better understanding and operationalizing trials that are considered across the explanatory pragmatic continuum, including Sean Triuk and Marek Zworenstein and other folks who have been pioneering this for some time. Building on the original article from 1967, kind of thinking about these trials along this attitudinal perspective and conceptualization. So explanatory trials, are generally speaking, are trials that are trying to answer the question, can this intervention or practice or program or drug or treatment, so on and so forth, can this object, so to speak, work under ideal conditions? And this is essentially trials that are set up to be tightly controlled, so to speak, where there's purposeful little variation allowed in the trial to really try to better understand, let's maximize internal validity and not focus as much on external validity, because we want to see if there's a signal there to begin with, and then we can expand it and try and create a little more representation of the quote unquote real world by moving more toward a pragmatic trial. And again, the pragmatic trial is really trying to answer the question, can this intervention, practice, program, drug, treatment, et cetera, work under usual conditions or quote unquote real world conditions, conditions that we see every day in the care that we deliver and the care that we receive? And can this intervention work under those conditions if it's found to work under more tight controlled conditions? Again, still leveraging usually a randomized controlled trial design or iterations of it, whether that be cluster trials, stepped wedge cluster trials, so on and so forth. But really then again, trying to maintain internal validity with an appreciation for and recognition that we need to pay particular attention to external validity, of course, and there's a time and a place for us to do so. And that the design of the trial is really what makes this more explanatory or pragmatic, and thinking about that from the beginning and the inception of the trial. So most of the work to date for the explanatory pragmatic continuum has focused a bit more on interventions. Again, drugs, patient-focused interventions, interventions that are on patient health outcomes. And so in implementation trials, of course, we're talking about testing strategies or the things that can help support the implementation, maintenance, and sustainability of a practice or program for which we know works. And we use a lot of different study designs, and we have the hybrid studies as well. But a couple of my colleagues and I, a couple of years ago, asked the question, well, we see, is it the case that all implementation trials are pragmatic trials because they're quote unquote done in the real world? And so we stepped back and looked at the literature and said, well, maybe that's not true. So can we take the PRECI2 tool and apply it to implementation trials with this recognition that perhaps in situations, in certain contexts, it really is beneficial for us to think about the ways in which we design our implementation trials purposely to match the overall intent of the trial and to answer the questions that are important to stakeholders and to partners. And so we took the PRECI2 wheel and adapted it for implementation trials, and trials specifically where we're focused on testing strategies to change provider or organizational or system level interventions versus trials that are focused on changing patient level interventions or patient level behaviors. And so these are the 9 different domains that we basically essentially adapted from the PRECI2 wheel, and talking about situations here where the practitioners, not the patients, are those who are the participants. So eligibility, what providers are eligible and why, and how does that map on or accurately reflect the types of providers that would be delivering an intervention in practice settings? How much extra effort is needed to recruit those providers? How different is the setting in which the trial is being conducted from the settings, broadly speaking, the full population of settings in which this intervention and the implementation strategies would be delivered? What are the resources needed to implement a practice or program, and where are those resources coming from, and who are those individuals? And to the extent that those individuals and resources, are they going to be available outside the context of the trial? Flexibility of provider-focused strategies. So how similar or different are the strategies that are delivered in the trial and the likelihood or flexibility of the strategies delivered outside the context of the trial? And so kind of taking it up a level and applying the flexibility to strategies in addition to flexibility of the intervention for domain number 6. Data collection, are we talking about original data collection or secondary data collection, the intensity, the frequency? How does this reflect, again, what is being delivered and what is being done outside the context of the trial? Primary outcome, is it important to partners? Is it important to end users? Or is it something that's looking more at the mechanisms of implementation, which would arguably then be a little more on the explanatory end rather than the pragmatic end? And then primary analysis, essentially, are we using an intent to treat analysis or a per protocol or on protocol analysis for that primary outcome? And similar to the PRECI2, we specified and encouraged folks to consider these different elements when using the tool and conceptualizing trials, implementation trials across the continuum. So thinking about, again, designing the trial from the beginning with these considerations in mind, and really leveraging as an opportunity to involve multidisciplinary stakeholders, researchers, methodologists, public health professionals, system leaders, patients, providers, in designing the trial so that it best answers the question that is most important to those stakeholders, again, as a proxy for reflecting what others are going to be interested in answering, and if they're going to be able to use the intervention and the strategy, if it's shown to be effective, again, after the trial in contexts and settings that the trial did not occur in. Switching gears again here, there are a lot of gears here going here. We have uphill or downhill or a lot of rolling hills here for those who are cyclists. Data sharing, I think, is another really important area where there's a lot of opportunity here. And I think to some extent we might be a little behind in understanding this and applying it. And I think that's in part because data and big data have traditionally been, biomarkers, more of the genetics and genomics, more kind of biomedical aspects versus some of the types of data and that we collect, broadly speaking, and generally in implementation science. And so we know that data sharing is a critical aspect of advancing science, and it's used to generate more research questions, increase transparency, accuracy, and providing an opportunity to give back to the communities and the patients and the providers who were kind enough to generate these data and share and provide the data. And so that follows on, and I'd be remiss if I didn't mention this because this has been a driving factor for us here at NIH to really try to think more carefully about this with respect to implementation science. So NIH recently had a mandate come out that all applications and those, of course, then that are funded, they need a data sharing plan that is far above and beyond what one might have had in the past, which is, data are available upon request. So there are a lot more specifications and requirements now, and this is going to be applicable not just to your biomedical lab data or genomic data. It's going to be applicable or is applicable to all types of data. Thus, it of course includes implementation science data. And so what kind of data are we actually talking about? Well, there are a lot of different types. There are a lot of different ways in which they're collected. And this all has implications for how they can be and should be and need to be shared. So we often have quantitative data and qualitative data, and then the explicit linkage and analysis of integration of mixed methods of qualitative and quantitative data for mixed methods designs. We often collect data at multiple levels. We often have smaller sample size among providers, among clinics and organizations. What are some of the challenges there with respect to small sample size and inadvertently identifying or de-identifying particular clinics because you only have 5 in a trial, but you need to share the data? So how do you make sure that you can share it in a way that others can benefit from and maybe redo the analyses to verify the results are consistent with what you reported, but also not to inadvertently identify those clinics because there are only 5. The different levels and the different data types, making sure that we have a way to share that that is actionable and that is helpful, but also certainly while maintaining confidentiality. And I think this is really important to the extent that it has implications for the type of data that we're going to be able to collect. So what are some of the ramifications here if we aren't as thoughtful as I think we need to be in maintaining confidentiality in types of data that are shared with respect to what organizations, providers, and patients are willing to, if they're willing to participate in studies moving forward, if there's a requirement here for data sharing. And that ultimately impacts our ability to answer questions if we're not able to collect particular types of data and not able to share those. And so I think there's a lot of opportunity here for growth and a lot of conversation that is critically important to get everyone involved in these. This is just a couple of relatively recent kind of workshops and a repository list on data sharing. So National Academies had a workshop a couple of years ago, which is very broad, but would encourage you to take a look at it if you're interested. We had a workshop a couple of years ago on specifically implementation data and cancer prevention and control. And there are some presentations and documents and a summary of the workshop on our website if you're interested in looking at that. And then these are just some of the generalist repositories I just wanted to put up here. Folks may be familiar with some or all of them, or they may be new. And that's to say that, not all of these are going to lend themselves well to data repositories and data sharing for implementation science type of data, but they are out there. And so I think it is it behooves us not to want to reinvent the wheel per se and create an entirely new repository that is just for implementation data, but rather to figure out what databases or what repositories might be best suited to share implementation data and how to do so. Last, but certainly not least, and it's not just an opportunity for implementation science to step into this space, but also the critical need for our field to do so to address climate change that affects us all. So and adds complexity to that is arguably unprecedented in terms of size, scope, and pace at which we need to work to mitigate the effects of climate change on health around the world. And this includes, for example, early warning systems for infectious diseases, disaster preparedness and response. And unfortunately, I'm sure we've all either experienced personally or through friends and family members the impact of climate change on health. Here we see an illustration of the impact of climate change on health, which kind of further exemplifies and illustrates just how broad this issue is, just how encompassing it is, and how complex it is. And as a side note, you'll, as you can tell, this is the most animated and sophisticated of my slides, and it's because it's not my slide. It's from CDC. So, but, you know, certainly I think exemplifies just how complex this is, which again, exemplifies how challenging this might be, but really the importance of our field in diving into this space. And I am admittedly not an expert in this area, but one of my colleagues here at NCI, Dr. Guy Lanetta, has been championing this area for us at the intersection of climate change and implementation science. And so here I'm borrowing from a paper that she led that laid out several case studies of how different countries have implemented early warning systems for climate crises. And they mapped some of the implementation barriers, such as conflict with tourism sector, funding for sustainability, political instability, to those case studies. And you can see, of course, this isn't comprehensive, but some of these, as you can quickly tell, are quite unique. So we often don't see things like conflict with tourism sector in a lot of the healthcare and public health research that we do. And so I think it's an opportunity for growth, and it's really incumbent upon us to step into this space. And I am heartened that there is an increasing amount of work being done here. And here, Dr. Netta and her colleagues kind of applied implementation science as a framework for how to advance research in this area. NIH has recently stepped into this space across all of our institutes and centers and emphasize the importance of climate change and health, recognizing that they're cross-cutting issues. And here we see this graphic here that dissemination and implementation science is really one of the critical aspects here with climate change and how we want to study it and what we want to support in studying it. And again, kudos to Gila for really being a liaison and championing this as a representative from NCI and broader NIH. And I think leveraging what we know from implementation science to mitigate the effects of climate change on health is really one of the most important issues that we need to work on and tackle in the coming decade and beyond. And I think it'll challenge us to think differently on it and on a scale and at a pace that's really unprecedented. And we have a real opportunity, of course, to improve population health. And I'm delighted really to see more work being done in this area. And for those who have been in climate science and climate change for quite some time, to be really open and welcoming to our field stepping into this space. And this is an NIH depiction here. And we had Gila again had a real opportunity to promote and emphasize the importance of interventions and implementation strategies here. So it is woven into the fabric of what we are supporting at NIH and the research that we would like to support and fund. So in closing, let me just note a few opportunities that are available here at NIH, of course, funding. So we have our signature funding opportunities here that cut across NIH. And there are different types of mechanisms, and they have for a different number of years and different dollar amounts. And these are just some of the examples of particular types of studies that we're interested in seeing in response to these funding opportunities, but certainly not limited to these. And you can see some of them touch upon methods and measures and de-implementation and some of the topics that I've discussed today. We also have at NCI specifically a funding opportunity on pragmatic trials, and not just pragmatic trials for interventions, but also explicitly calling and encouraging applications for pragmatic trials on implementation strategies. And so that I will close. Thank you very much for your time and for the opportunity to speak here today. And this is my contact information. If we're not able to get to all the questions, or if you think of questions afterwards, feel free to email me. Thank you.
Excellent, fantastic. That was a fantastic talk, Wynne. Thanks so much. And I would just remind everybody, either put your questions in the chat feature or raise your hand. While we're waiting for other questions, I had a couple to start us off with. So really great to see the description of the rapid cycle intervention and evaluation work. Can you speak to the role of process evaluation in that?
Yeah, that's a great question. My initial reaction is rapid ethnographic assessment. That would be a component there that would, necessitate original data collection, which again, I think as we conceptualized it, trying to leverage or maximize the use of existing data and secondary data, because we know that primary data collection isn't always rapid per se. I think, again, we are seeing more techniques and ways to collect qualitative data that like ethnographic assessments and rapid qualitative interviews and analysis that might lend themselves well to process evaluation and those types of context specific data that could be collected. So I think that might fit well to complement kind of the overall study designs of the iterative study designs that are one of the key elements of rapid cycle interventional research. I think it also, is a question of what is most important, what's feasible, and to what extent maybe you can add in some of the process data collection and analysis, just how much you're willing to do relative to how less rapid or slower it might be relative to how quickly you want that answer. So I think it's a balancing act, but I am encouraged to see more, methodological approaches in the qualitative research space that would lend themselves nicely as a complement to this.
So thank you. And then on the same topic, one of the pieces of feedback that we often get from peer review panels here in Canada is when we're doing research and we select a proximal outcome as a primary, then we often get the feedback that looking at guideline uptake is not as well received as looking at impact on patient admission to hospital or patient quality of life or things like that, and our health system outcomes. And so advice for people on how to frame that so that it is more well received by peer review panels when we're looking at, because that's such a big feature of being able to do the rapid cycle research. And if we can't sell the idea of a proximal outcome, it's, we're not gonna succeed. So what's your strategy on that?
Yeah, great question. I think at least in the study sections in which we see a lot of the implementation grants here at NIH come through, the study sections reviewers tend to be pretty open to the use of proximal primary outcome as, admin data, audit of adherence to clinical practice guidelines as a proxy for patient health status. So it might be, but certainly in other study sections or broadly speaking in other funding agencies, that could be quite the challenge. I think to the extent that you can demonstrate the correlation or a strong correlation between what the proxy variable is, the more immediate variable outcome, and the longer term outcome is, based on what existing data are there, and that should actually help inform you what primary proximal outcome you're selecting. I think that could be helpful, just making it more explicit, that, you know, there are probably other factors at play, but addressing this, for example, clinical practice guideline to make sure that patients receive this drug and the drug has been shown to work at this level, that's where we need to go. Sometimes it can be a secondary outcome too. Again, you know, broadly speaking, not necessarily specific to rapid cycle interventional research. But I think one of the important ways to leverage or to look at that correlation and use that to determine what is the most appropriate proximal outcome, you know, from a scientific perspective as well as from a grants personship perspective.
Excellent, thank you. And then for the data sharing piece, so this is a requirement as well in our grants here. So if you're applying for an NIH grant, is there, so my next couple of questions are going to focus specifically on NIH, because I know a lot of people on the call maybe haven't applied yet, but are thinking about it. So is there a separate section that that you have to fill out around the data sharing plan? And then secondly, what advice do you have for people who haven't submitted to the NIH D&I panels yet? And your advice to optimize chance of success.
Yeah, great question. So the data sharing management plan is new. There are a bunch of resources on the NIH website that I'm happy to share that include templates, guidance, the exact requirements for what needs to be included that meet the specifications of what the applications must have. And there's also some work then once you get funded of what that might look like and some of the tweaks that might need to happen there. So there are a lot of resources. I am, you know, there's been some embracing of the data sharing issue among the research community, and there's been certainly some pushback. And so I think NIH has done a really nice job trying to address those issues, and they have a lot of resources for what the data sharing looks like. I think it would be helpful, in my opinion. We've had some conversations about trying to develop case studies of data sharing and implementation science. So those are kind of ongoing right now. And certainly we'll let folks know if and when we're able to generate those as examples, again, specifically to implementation data. Your second question around review, broadly speaking, in NIH study sections and suggestions for that. I would say if I put my former academic hat on when I was an assistant professor, one of the best pieces of advice I feel like I ever got with respect to writing grants is to see a copy of a recently funded grant in that topic area that has gone to the study section that you're planning to submit and that's funded by that agency. So in that regard, when I first came to NCA, I said, all right, let's try and get some sample grants up on the website and get the necessary approvals for doing so. And a lot of different institutes and centers have that already. So we currently have, I think, 12 different sample grants, including several of the different mechanisms up on our website that are freely available that include the specific aims and the research plan. Obviously, they're not going to include the salary or bio sketches or any of that type of information, but I think that's one of the things that I point to prospective applicants to look at first, just to see how they're written, the scope of them. You know, the R21s are going to be smaller than the R01 grants, and what kind of is an exemplar, because obviously these have all been funded. I would take advantage of any resources you have at your respective institution for kind of a mock grant review. If you have those, ask somebody who has been on the study section in the past couple of years but has cycled off, you know, to potentially take a look at your grant. I know folks have done that before as like a pre-read because they know the study section, you know, obviously recognize that there may be some conflicts there that you need to navigate, but if they're not on the panel, then I think I think they have like a year or two after which they can't do certain things. But talking to people who have been on the panel, and then contacting us as program officers here at NCI, elsewhere at NIH for the program announcement on dissemination, implementation, research, and health, the main one. There are contacts for each of the institutes and centers that are part of that funding announcement. And I will just vouch for all of them that they're all good people. And I to any of them, feel free to contact me. And I think, we're here to best help support the science, which means supporting you, which means reach out to us, and that's what we're here for. So feel free to contact us.
No, I think that's fantastic. And I do want to emphasize that to the people on the Zoom call today, that this is very different from the CIHR, where, within the NIH, people like Wynne have, advanced training in this research area and are really there to kind of help support the process. And so very different from, if we contacted the CIHR around a grant where they wouldn't be able to provide that same type of guidance. So this is very, very different. So I would encourage people to take Wynne's advice if you are thinking of applying to the NIH to really leverage the amazing expertise that they have and that they make available. I think it's fantastic. Just a couple of other questions. Well, actually, one comment that your idea of the case studies on data sharing, I think would be really terrific, and maybe thinking about turning that into a paper for implementation science, since it is something that all of us around the world are kind of struggling with, or not struggling with, but having to develop an approach to it.
Sharon, have you hacked my NIH email account? Because I just sent an email to implementation science and
Really?
ISC last week about that topic, because I think it's a real opportunity, and the case study aspect is something that we've been discussing as well internally in terms of, how can we support this being generated, and not in a way that's us being prescriptive of like do X, Y, and Z, but let's hand it over to the researchers and the practitioners of how did you do this, still being consistent with the requirements, of course, but I think, we're all kind of in a space that we're not very familiar with. So if I don't know if there's an associate editor that would also want to support that idea or whatnot, or editorial board member, Sharon, but yeah, it's something that I think I think that case studies and again, like sample grants are really helpful. So we're definitely thinking along those lines of how to, not just a paper for a paper's sake, but, case studies and examples and, voices from the field.
No, I think that's great, and I'm happy to nudge on that as well. So that's fantastic. And then my last question, because we're getting close to one, is we have a cross-cutting theme within our network as well on mentorship and career development, and you've had a very different kind of career pathway. And I wondered if you could speak to what advice would you have for somebody starting off in the field, and in particular thinking about you're not a traditional kind of person working within a university environment, but you're still doing a lot of amazing science work as well. And I was wondering if you could speak to how you got to this point, and any advice for people starting out.
Yeah, great question. I think I'm probably somewhat of an outlier in my path, that I didn't do a postdoc, and I went straight into academia as an assistant professor and was there for a while, and then decided that for various reasons, I felt like being in a position where I am now is the best way for me to best help support others to do the science and what I'm able to do on this end of it. I am very fortunate. I think that I had a fantastic advisor in graduate school who had, a history of tens of $million of funding from NIH. And so I had a pre-doc fellowship. So I was I learned how to write these grants. Are very different writing skill set. I learned how to do that in graduate school. Very well supported by my mentorship team in terms of reaching out. I think I reached out to Jeremy Grimshaw when I was like a fourth-year PhD student and asked him some questions to come give a talk. Brian Mittman, I did the same. If I could give advice, it would be to identify champions in your space who will be in your corner and who can give you really good professional guidance and be leaders and mentors for you, and hang on to those people as best you can. And really just, there are a lot of good people, and this is a really good space to work in. And I think, people who have been in it for a while can help you navigate some of the challenges you might encounter. And at the end of the day, it's what makes you happy, and finding that spot and recognizing that, what makes you happy one day and in one part of your career, you may, want to switch that up later, and that's totally okay.